Good afternoon, everybody. Thank you for joining us this afternoon. My name is Letha Matthews. I'm a Division Chief of Neuroanesthesiology at Vanderbilt University Medical Center in Nashville. And it is my distinct pleasure to introduce two of our expert speakers on this subject of cervical-occipital fusion and what comes after that. And our first speaker, Dr. Elizabeth Abramovich, she's a clinical professor of anesthesia and vice chair of education at New York Medical College, and she's also the associate program director of anesthesia residency at Westchester Medical Center, Valhalla, New York. And she's going to be talking about, we all know that there's a lot of patients who have cervical-occipital fusion can have a lot of problems after surgery, immediately after surgery, or even few, days or months or years down the line. So she's going to talk to us about whether to extubate, what do you do with these patients at the end of surgery. And then I'm also going to introduce our next speaker, Dr. Maria Bustillo. She's a professor of clinical anesthesiology and neurologic surgery at Weill Cornell Medical College. And she's also the director at large of Society of Neuroanesthesia and Critical Care. And she also serves as the chair of the scientific program at the PGA, the New York Society of Anesthesiologists. And she's going to talk about, patients with cervical occipital fusion. Well, how do you take care of them afterwards? Okay. So my first speaker, Dr. Abramovich.
Good afternoon. Thanks for coming after lunch. Dr. Matthews, thank you very much for the kind introduction. So we have some ground to cover. This is the plan of the presentation. We'll just talk about the airway complications in OC fusion and where they come from and how to manage the risk of those. We'll talk about how often failed extubation or failed reintubation after OC fusion occurs, and can we manage that as well? And finally, should we extubate in the operating room? And I will also share with you some new data from my institution that may serve as a potentially a guide to prevent some of the most severe complications postoperatively. So first, we talk a lot about spinal surgery, cervical spinal surgery, and airway swelling. I think there's a lot of discussion. Oh, there was just swelling. The patient had swelling. And so I refer to this paper because it's a very nice illustration of what happens after anterior spine surgery. And I think that if you take x-rays, if you can see my, okay, you can, but it doesn't. Anyway. It is true. Okay, maybe. Yeah. Does it work? Yeah, it works. Yep. Okay, great. So you see those arrows, it shows you the prevertebral soft tissue. And if you have a transoral operation, there is a lot of swelling. This is pre-surgery and this is after surgery. You see that gray thing. The upper airway surgery in the C4, C3, C4 area, there's also quite a bit of swelling before and after. But this is definitely thinner, let's say 2-3 millimeter range. And then if you look at the ACDFs that are done lower in the C5 to C6 area, there's even less swelling. So I think it really is germane to anterior surgery. And if your patient has something that we call often 360 surgery, meaning an anterior component to it and a posterior component, regardless of the extent of the fusion, I think that is something that needs to be definitely taken under consideration. But this is not a very big problem because it is usually something that goes away unless there is bleeding. And so I want to share with you this very nice and I think reasonable and structured way of performing the cuff leak test, which I call the Rush protocol because it comes from the Rush University. And they apply it to anybody who has both anterior and posterior cervical fusion. But basically, you can read through this or you can refer to the paper, but the idea is to establish mechanical ventilation, the high tidal volume. They want 8 milligrams per kilo of ideal body weight, and then they deflate the cuff and skip 2 cycles, and they average the tidal volume in the next 6 cycles. And you have to have, an appropriate, whatever it is, you make a note of it. And once you make a note of it, you can repeat that test after surgery And I guess what is considered, a favorable time to extubate if you have a leak test of over 200 milliliters after surgery. So that's one structured way of doing it, and probably all of us should have some sort of a system, because just doing it by sort of feel is probably not a great idea. So here's a case. This is a trauma patient. I work in a trauma center, and most of our cases are cervical traumatic injuries. She's 76. She was in a motor vehicle accident 2 days prior. She's an Asia E, meaning neurologically intact, and her BMI is kind of fine. She has two problems you can see here. So this is an anterior arch comminuted fracture, and she also has a C2 fracture, which goes to the lateral mass and involves the intervertebral foramen. She also has ligamentous instability of the cervical spine, and in addition to this, a grade 2 blunt vascular injury, the dissection of the left dominant vertebral artery. And in the MRI report, they said that she's got some prevertebral soft tissue and swelling, and then hematoma from the Bayesian to all the way down to C4. And the plan here for this patient is to have close reduction of a C1 on C2 subluxation and an occipital to C3 fusion with bone grafting. So this is one uneventful intubation. Anesthesia time was 4.5 hours. She had intraoperative neuromonitoring. She received fentanyl prior to extubation. Surgery time was about 3 hours, 15 minutes. She didn't bleed much, 1.5 liter total for the case. Urine output was excellent. She was extubated in the operating room, transported to ICU with oxygen via nasal cannula, and the saturation was reported to be good. And then the post-anesthesia note said that in the ICU, the patient was arousable and had a nasopharyngeal airway in place. And this is the patient's post-operative cross-table lateral X-ray. And you see here, this is the endotracheal tube, and behind the endotracheal tube is the patient's airway. And as you see, the angle of the mandible is practically wedged against the spine. So would you have extubated this patient is the question, knowing what you know. And so what happened in the ICU is over time, we got to a situation where they were unable to intubate, unable to ventilate, perform a cricothyroidotomy, and that resulted in an emergency tracheostomy. And is this surprising at all? The outcome was such that, weeks later, there was an ENT exam which showed laryngeal edema and obliteration of all laryngeal structures except for severely edematous arytenoids, and they couldn't visualize the glottis on ENT exam. And she was neurologically intact, and she went to rehab with a feeding tube and a tracheostomy. So really a terrible outcome for this very functional 76-year-old. So same X-ray, and the question then is, should this patient have had revision of the fusion surgery? And as we ponder that, we'll move on and discuss a little bit the mechanics of occipital cervical fusion and as it impacts the geometry of the upper airway. So when you look at the radiopedia and see, what is it that people want to know radiographically when assessing patients who have had OC fusion, the report contains a lot of elements, including a comment on complications, and those absolutely mention no airway at all. And then ultimately, what they're explaining to us is the idea here is that the fusion should be done such that the patient's horizontal gaze is perfect. They don't particularly care whether the patient's chin is tucked in, so translated backwards or flexed, if you want to say that, at the occipital-cervical junction. The idea is the patient should be able to see in front of them. So proper alignment allows for horizontal gaze, and that's the goal of all that. But I think it's a little more complicated than this. And one of the measurements that can be done and really is important for the rest of the discussion is the occipital cervical C2 angle, cervical second vertebra. And it is really also called a McGregor line, but it looks at the most caudal point of the occipital bone here in B, and the line is drawn to the posterior edge of the hard palate. So that's part of the angle. And then the second one is through the C2 bottom end plate, and the two lines should cross at some point. But here, we don't have room for this, so this OC2 angle is measured kind of here. And I'll give you some more examples of this, but this is basically skull, bottom of the skull, hard palate to the bottom of the C2 end plate. Okay, a common complication after ossifusion is dysphagia, and people write a lot about it, and it's all over the orthopedic and spine literature, and we know from these publications that the OC angle, as here, really has a lot to do with dysphagia. And so how is that related to the airway? Well, it is because dysphagia is related to, as you see here, this is a patient before ossifusion. This is a patient after ossifusion, and you see the narrowing of the airway here in the pharyngeal space by the displacement of the jaw, kind of translation of the jaw backwards. And this is a patient that actually had a problem, major problem, and that problem is seen here. So this was the angle before the fusion. So you see two parallel lines practically, and they call it -2 degrees. After fusion, the patient's angle is -15 degrees, and they had to reoperate on this patient. The dysphagia was so severe, this was an elective operation, and the angle is now at -4. So for us, really what is really important to remember that the delta OC2 angle in this particular instance was 13. So remember that number. We'll come to this in a second. Now, this is not just a trauma problem, right? Because here you have an explanation as to how this happens, that if you rotate the kind of the flexion, so the skull is rotated downwards, then it approximates the posterior pharyngeal wall to the spine. But it can also happen when in patients who have rheumatoid arthritis, and Dr. Bustillo will touch more on this because her talk is more about the inflammatory and congenital issues. Then the same thing may happen as that subluxation is relieved. So in other words, there's again a translation of the skull relative to the spine. There's a different mechanism, but the net effect is the same. So well, we have to accept that the upper airway geometry changes after ossifusion quite often, and that's what causes dysphagia. And that down the line causes aspiration in many of these patients. They also can have upper airway obstruction, and it can be, you can understand that there are different levels of that, and some of these patients even develop obstructive sleep apnea. So let's start with that. This has been known, maybe, there are cases that precede that. The first one I found that really was convincing was 2007 by Yoshida. He reported a case of a patient who, again, same thing. The black line is not as visible, but that's the C2 end plate. And so this is a patient in neutral position. They flexed the patient, they fused the occiput to the cervical spine. And as you see, this is an 80-degree angle. That's how they started. That was neutral. And then they converted these patients to a 0-degree angle relationship between the skull and the C2 vertebra. And now we can see how tight the space is here. Like if you pay attention, the airspace here is very broad, and it's very narrow here. And the patient, all kinds of complications, as they say, this is a Japanese paper, the patient suffocated shortly after extubation, despite being fully awake. And then he goes on that he could not breathe without mandible protruding anteriorly, so they were pulling the mandible out, and that kind of made things better, and then suddenly suffocated again. And they were so impressed with this that they actually, ultimately had to redo the fusion, and the angle, they decreased the angle to 14 degrees. So the delta is 14 degrees here. And then he went on to look at this after surgery, and then they went to analyze that airspace. As you see, the epiglottis here is very clearly visible. There's basically no space up between the epiglottis and the spine. And this is after the revision surgery. I mean, now that we know what we're looking at, it becomes pretty clear that this patient had no chance. And so what he's saying here, it should be kept in mind that an adequate fusion angle is mandatory to avoid this catastrophic complication, even in short occipital cervical fusions, especially in patients with rheumatoid arthritis, but it of course applies to other people. Mechanics are mechanics. And so this is 2007, right, a long time ago. And then he goes on to publish, to collate 5 more cases, and they're all very similar. And these patients were period to extubation or airway cuff removal, interesting criterion, but it's weeks. And some of them had tracheostomy, some didn't, but it really, some of them required a change in the fixation angle, quite a few of them are removal of the implant. So, you know, it's very dramatic and very complicated course. Now, 2 years later, someone actually, beyond the angle, went through the trouble of measuring the diameter of the airway after these OC fusions. And there is a correlation of, again, dysphagia and dyspnea. This is not perioperative management, but looking at just sort of the downstream effects of the narrowing of that pharyngeal space. And they had group A that had dyspnea and dysphagia, and group B that had none. And if you look at this delta angle, it was about 13 degrees in the group A, meaning the ones with symptoms, and almost no change in the angle in the group that had no symptoms. So they only had 5 patients in the group with the dysphagia and the dyspnea, and 24 in the other group, but there was a significant difference in the surface sort of area of the airway, and you can measure it on CAT scan before and after surgery, and in the change in the angle. So, you know, this is like 2 years later, like the story becomes very clear. Case reports, 2011, same problem. This is a patient with a short fusion who now needs an extended fusion to the occipit, big airway here. This is after surgery, see almost nothing. Patient gets extubated. You can tell what happens. Intraoperative fluoroscopy for adjustment of fixation angle and the airway diameter. And then they realized, you know, that this is a big problem. They extubated over the patient over an airway exchange, and things went fine ultimately. So they needed a re-revision. This is New England Journal of Medicine. They publish things that are unheard of, right? 2017, same thing. You see, this is a patient before surgery. This is patient after surgery. And dysphagia, nasopharyngeal regurgitation, delayed aspiration due to hyperflexion of upper cervical spine. So this is very well known. It's just that we haven't internalized this. This resolved after re-operation and adjustment of that angle. Another one, 2023, we don't have to spend too much time on this, but cannot intubate, cannot ventilate, you know, all kinds of maneuvers, jet ventilation, etc. And after some supportive treatment, we sent her to the intensive care unit ward with a tracheostomy. Terrible. So the question is, does delayed extubation guarantee airway patency after OC fusion? Because that's what the data we have. So two studies, 2 papers that have been published thus far. One is from the Journal of Neurosurgical Anesthesia in 2022. It is a retrospective look at patients, 135 patients over a long time, 2009 to 2018, so almost 10 years, and not all of them had OC fusions. But to make a long story short, 68% of them were extubated in the operating room, 32% had delayed extubation, and you know, they're looking at predictors of who really underwent that delayed extubation. It had to do with age and surgery length, and C2 as the highest level fusion percent. You know, all these things that we take under account when we think about patients being in the prone position for a long time. But the rate of postoperative complications, whether they were extubated early or late, was not different. And if you look at the subset of patients, and I'll show you a little more detail in a second, the emergent airway obstruction only occurred in those patients who were extubated in the OR, and not meaning that patients were healthier, they didn't have their surgery wasn't as long, etc. And both, however, had occipital fusion. And second paper we have is from the Journal of Clinical Neuroscience 2017. Am I doing okay with time?
Yep.
Yeah. And this is from the Toronto Western Hospital. They looked at 59 OC fusions only, also over 8 years. So as you see, these are not super common, even in big centers. And of those, they had adverse airway events in 27% of patients who were extubated late. However, the emergent airway obstruction occurred in 2 patients, and both were extubated in the operating room. So you would think they were low risk. And then looking at things in more detail for the mixed cohort from the Journal of Neurosurgical Anesthesiology, 135 patients, and of those, occipital fusion was done only in 24, and 24 of those were extubated in the operating room. 2 out of 24, so you do the math, required emergent airway management. And in 20 of these fusions, they said the extubation was delayed and there was no airway obstruction. So they inferred from that it was the problem of early extubation as opposed to late extubation. And you know, the airway complications were no different, so you would think you have an answer here. But I think it's very misleading, as I'll show you right now. This is a meta-analysis that was just published. I guess I can't call it a meta-analysis. They call it a systematic review in the Journal of Clinical Neuroscience, again, September of this year. And they evaluated the incidence, severity, and risk factors of respiratory adverse events. You know, it's a neurosurgical paper, so it's respiratory adverse events, and it's a mixed bag after fusion, occipital cervical fusion, and they call those respiratory adverse events reintubation failure, upper airway obstruction, delayed extubation. So again, a combination of things, but I'll separate it for you and you'll see how horrible it is. So the demographics is they looked at a variety of massive literature review, but they ultimately found 28 studies that really pertain to OC fusions for which they had data that they were looking for. So in other words, there were more patients with OC fusions, but they were unable to identify details pertaining to extubation and report of subsequent respiratory status. So ultimately, they looked at 28 studies, and there were 429 patients that were included in those studies. And 12% of them had respiratory adverse events, 12%. So 12%, that's 50 patients. Okay, so now we're going to look in more detail at the 50 patients. And this is their cohort. They had 35 adults, 15 pediatric patients. Congenital anomalies accounted for 24% of their patients. Inflammatory, so rheumatoid arthritis or ankylosing spondylitis, 24%. Tumors, 22, and only 6% of those were trauma patients. So only 6% of these patients that had adverse respiratory events were normal, had normal anatomy prior to experiencing this problem. And they had the angles, the OC2 angles were available for 6 patients preoperatively and post the delta itself, so without the absolute numbers for another 23. So looking now at the major problems, as you see here, I put this free Wikimedia, it's a completely legitimate picture. It's a horror show. When you look about this, difficult intubation, 45%, for altogether 41 in the whole cohort. Location of the initial extubation didn't really matter. Operating room 35. It really doesn't matter very much. Because if it's in the ICU, 60% of them had problems. And extubation there didn't seem to matter either. The failed extubation, very high, overall 40 out of the 50. And failed initial reintubation, 18 patients. The serious respiratory adverse events. Okay, so I have a little more about this. So this is, there are only 39 patients there, but many of them had more than one serious event. So there are more events than patients. And so lethal complications pertain to 6 out of 45 events in 39 patients. So 6 patients. I mean, it's a huge number. Severe, which they call, that's their terminology, revision surgery, requiring revision surgery, 5 out of 45. Tracheostomy was performed in 41% of all patients, it's 16 out of 39. And they call it serious, events, and 32% if you look at the total. So we're almost at the end, but you see how serious the problem it is. Failed extubation rate in this group of people that already are falling under the category of complications, 58%. Okay, so I'll share with you some unpublished data that we just submitted this paper publication. This is a retrospective cohort of 22 adults, normal patients who had trauma to the cervical spine. And what we did here, we measured their C2 angle based on pre-op and post-operative CAT scans and X-rays. A neurosurgeon did that, it's pretty thorough, and then we divided them into quartiles. And remember that number I told you that the delta for dysphagia, that angle change was 13 degrees. And so our fourth quartile, the more extreme quartile of angle change is 12 degrees, over 12 degrees. And then if you look at the proportion of patients needing reintubation, we have 3 out of 6, so that's 50%. Proportion of patients with dysphagia, 6 out of 6, that's 100%. Proportion of patients with severe dysphagia is 4 out of 6. And proportion of patients who need a surgical airway is 3 out of 6. So that's 50%. So if you look at the regression curve, and that there's one outlier here, but I did like a combined outcome. So this is a composite outcome of either tracheostomy or PEG or both. Because these are very severe outcomes, if they're related to dysphagia, not because the patient's unconscious, then this angle is about 12 is right here. So most of these patients, and one we had to exclude for this purpose because the patient had a PEG before surgery because of previous traumatic problems. That you see that we may have something there. Obviously, the numbers are very small, and we look at larger data sets now to see if we can reproduce it. But, okay, be it as it may, it's a really difficult situation to be faced with if you do not look at this angle. And we're saying, okay, now that we know that this has something to do with potential for severe respiratory problems, maybe before we finalize the fusion, we should do an X-ray and look at this together with our CAT scan, intraoperative CAT scan. We do those very often with the surgeons. So that's something to think about. I just want to remind everybody that we have a new guideline, the 2022 guideline, that ASA guideline pertaining to the extubation of the difficult airway. And even in these cases, if the angle is unfavorable and the surgeons are unwilling to change the angle, redo the fusion, an elective tracheostomy should be on the table. And I think that when you extubate these patients, it doesn't really matter if you don't assess the patency of the airway, mechanically speaking. And in conclusion, airway complications in this fusion, OC fusion, can be lethal. Failed extubation after OC fusion may be of surgical origin. And that is preventable. That is a modifiable factor. Reintubation may be impossible. So please think, front of neck access may have to be considered early. Plan to access new airway geometry. If favorable, extubate in the OR or consider elective tracheostomy. And ultimately, we still don't know everything, so you should be on the lookout for more information. Thank you.
Thank you, Dr. Abramovich. Dr. Bustillo.
Hello, everybody. So we are going to review a little bit some of those topics that were already mentioned, and then we are going to go over what are we doing in my institution to prevent problems with the OC fusions, and how we should handle the airway of a patient that comes with an OC fusion, whether it's for a revision or for other types of surgery. Here? Okay. I hate this. Okay. So I have no conflicts, and this is our main objective. Just to review briefly the difference between just a posterior cervical, where you have mobility of that atlantoaxial are joined there, versus your occipital cervical fusion that involves fixation all the way from the base of the skull and was originally described by Forrester in 1927 as going from the occiput to C2, but it can go lower. And the truth is that diffusion itself, even if you don't have compromise of the airway initially, substantially alters the biomechanicals of the spinal column and the range of motion of the neck. Occipitations can be associated with multiple issues, trauma, as was described before, congenital dysplasias that we do a lot with Chiari malformation patients, oncology patients, infections, degenerative diseases like rheumatoid arthritis, where the most prevalent cause years ago for ossifusions that has changed now to diseases like Chiari malformations or Ehlers-Danlos. Ehlers-Danlos is right now the most prevalent of these scheduled occipital-cervical fusions. And we have the congenital occipital-cervical fusions like Klippel-Feil syndrome. Klippel-Feil, where are you? Okay. Is a condition where a segment of the cervical vertebral bodies fails to separate during when the baby is forming, and when they are born, they have other characteristics. They have a low set of the hairline, they have very short neck, they have very wide necks also, they move nowhere. And there is a particular variant of the Klippel-Feil that is called the atlanto-occipital assimilation. And they have severe neurological symptoms, they have a spinal cord compression, they have other anomalies inside the airway. Humongous epiglottis. Those patients, they need a nasal fiber optic intubation, but that's a variant that you can find. So the group of Anna Gorbacheva, they did a bibliometric analysis looking at the trends of ossifusions, and they reviewed the Web of Science database. They look at articles published from 1984 all the way to 2023. They found that rheumatoid arthritis was more prevalent at the beginning, like I mentioned, but Ehlers-Danlos is the most prevalent cause right now. Publications peaked in 2020, significant increase, and then it started to go down from there. The countries that are publishing the most on this issue are the United States, China, and Japan. And in all these studies, dysphagia is the most prevalent complication. And again, important for us because it translates to airway. And we already saw that in our previous talk. So George published this article on the considerations on revision of occipital cervical fixations for dysphagia. He came on the conclusion that yes, fixation in the hyperflex position is the cause. There is this causes a decrease, as we mentioned before, in the oropharyngeal angle. The head position influences also tonic neck reflexes and muscle length, which alters the genioglosal muscle activity. The head position alters the tongue position in relationship to structures of the posterior oropharyngeal cavity. And in addition to that, patients who have been fixed in this kyphotic position may suffer from contractures of the suprahydoid muscle that cause biomechanical compromise that is that you don't see on a patient that has a neutral position. And here he has, this is one of the cases that he reviews where you can see the very small size here of the oropharyngeal airway, and you have this hyperextended position. And when I talk later about airway management in these patients, it's important to remember on this position, you don't have any movement whatsoever. Mask ventilation is critical. It's almost impossible if they are really flexed. The other thing is if you do an oral awake fiber optic, you can pass your fiber optic, you probably can see the vocal cords, but your endotracheal tube is not going to turn down. It's a lot more rigid to go down. So in these cases, you probably need a nasal fiber optic. here we have another case, and you see the airway here and the difference with the airway after diffusion. So in my institution, they have been looking for how to predict clinical outcomes by using morphometric changes in adults with complex Chiari malformations. We do a fair amount of Chiari malformation in my institution, and they're all under Jeff Greenfield, but there is a series of surgeons that are, right now only one, that are helping him with the Occipito cervical fusion. And what are they doing? When patients are identified as they could benefit from an occipital cervical fusion, and this is a particular type of patients, are patients that they don't only have a headache associated with the Chiari, they have headaches, they have dizziness, some of these symptoms changing with positioning. They can they can have hemodynamic issues associated with neck positioning. What they do is they place these patients on a hard collar for 2 months. And the idea to put them with a hard collar is two. One is to see that the symptoms go away. If the patient's placed on a hard collar, on a neutral position, the symptoms resolved or improve, then they know the surgery could help them. There is no point to do the surgery if the symptoms don't improve. The other reason to have the hard collar placed for 2 months or more is to see if they can actually be compliant with hard collar, because they will require the hard collar after surgery to be sure the fusion heals appropriately. So they place the hard collar, they take X-rays and CT scans of the patients with the hard collar, without symptoms, and they look at the angles. And they look at the occipital to external acoustic meatus angle. They look to the OC2 angle. They look at the C2 tilting angle. And they look to the narrowest oropharyngeal airway space. And the goal is to achieve similar angles to the pre-op angles in the post-op studies to avoid complications. So as we said, excessive flexion we know causes a problem. They did a retrospective cohort study. They looked at 39 patients done at our institution. 2 of those patients required revision surgery, and I will tell you why later. Dysphagia was in those 2 cases present, and 1 patient that had a swallowing study developed a high risk for aspiration. What they are doing is following these morphometrics intraoperatively. They bring the patient in the operating room. They look at they place the screws. They do films before placing the rods. They look at the angles and they see if the angles that they have at that moment are the angles that match the preoperative angles. And if they are happy with them, they put the rods. If they are not happy, they reposition, they take shots again before they place in the rods. And in that way, they have avoided most complications. So here we have one of the cases that require the re-exploration. These are the preoperative angles. The post-operative angles, and this patient was complaining of dysphagia, look at the space, and look at the changes both in the occipital cervical and in the occipital to the external meatus angle. They didn't do the correction intra-op, and that's why this patient had these angles. This patient was brought back to the operating room within 2 weeks, and the angles were changed. And these are the initial angles intra-op after the last ones before closing. and these are the angles 3 months later, very close to the preoperative angles. We have, this is the other case, also where we have the preoperative angles. These are the initially intra-op angles, and this is the opposite. In this case, they were extending too much the neck. You see the oropharyngeal airway opens up, and this angle is quite different from here. So they managed to reposition, bring the patient back to close to preoperative angles, and this is 3 months after surgery. So it's possible with the morphometrics to adjust the angles. And in both of these patients requiring revision of positioning, they found that there was a significant decrease in the OC2 and in the OEA angle compared to the angles after the initial surgery. The postoperative dysphagia resolved in both of these cases. And in the non-revision cohort, they found that all the angles were close to the pre-op angles or with a slightly increase in the angles. And that suggested that there is a predictive role in using the morphometrics before and during the procedure. And this is a graphic of what they do, and this is the particular case of a Chiari patient that goes from the flex position during the surgery when they do the decompression for the Chiari, and then they reposition and they bring him they brought the patient back to the neutral position. Okay, again, dysphagia we know is described in the OC2 angle has been described, and we know that a reduction of 5 degrees or greater can produce postoperative oropharyngeal stenosis. The sum of OC2, the C2 tilting, and the external, the occiput to external acoustic angle has been later described to encompass both the craniocervical junction alignments and the cranial transverse motion, and acute decreases in the occipital to external, the external acoustic angle significantly correlates, at least in the numbers in my institution, with the narrowest oropharyngeal airway space, even more than the OC2 angles. So what we should do when you get a patient that comes with an OC2 fusion and is coming for a revision or for other kinds of surgery, you should look at preoperative symptoms. Is the patient having any kind of dysphagia, coughing? Did the patient develop OSA after surgery? That's another indication that they're probably getting obstructed. Look at the x-rays, look at the CT, I do that particularly with our surgeons, and look for evidence of hyperflexion. Remember that this is a fixed neck, it's not going to move anywhere. It's usually neutral or slightly flexed or very flexed. The oral, pharyngeal, and the laryngeal axis are not going to be aligned, so it's going to be difficult to intubate, just starting with that. Most of them have a limited mouth opening due to the that is possibly associated with muscle stiffness around the area, and some of them had prior trauma. So you should review the CT, you should review the MRI, you should do your regular airway assessment, look if the patient has any other neurological symptoms, any myelopathy or any other issues like a prior tracheostomy, and discuss the plan with your team when you are going to take care of these patients. And this is one of our patients. She had an OC fusion for a Chiari, and she came a year later for a lower back procedure. And we review her films. She looks here slightly flexed, but her airway has a good diameter. On the physical person, she was a little more neutral than the X-ray. And we were able to do an away fiber optic on her and do her surgery uneventfully. We had no problems. Always remember, fiber optic intubation, awake fiber optic in these patients is probably the gold standard. Try to maintain a spontaneous ventilation, particularly in those patients where you know you are not going to have an easy time trying to mass ventilate them. Oral route for awake fiber optic is probably okay, but in patients that are hyperflex, nasal is probably the way to go, and do good topicalization of the airway. I put question marks on sedation because my sedation is talking to them. I bore them with talking, but I don't give sedation when I am really concerned about the airway. And have your backup plan ready. Video laryngoscopy can help you maybe to improve visualization or using a combined technique with fiber optic, but you need to have a good mouth opening, and sometimes you don't. LMA could help you to ventilate in these patients, but if you are hyperflex, the LMA is not going to go easily. And always have a plan for a surgical airway ready to go. This is the latest of our things our surgeons do intraoperatively. They do a 3D post-op after rod placement, and they look for alignment. They look that the rods are, all the hardware is well placed. They do that, they do all this before starting to close. They look at that the patient is not hyperflex or extended. You can see our endotracheal tube here. And there is this a nice picture for Halloween. And the last video that I want to show you is, no, this is not what I want. Had been working with one of our junior faculty. He's an expert on augmented reality. And I have been trying to develop a model to look at the CT on augmented reality and be able to identify the airway or changes in the airway better. I will let him to explain it to you directly on the video, but again, it's a working process. We are not there yet.
Hello, everyone. My name is Rohan Jatwani, and I'm an anesthesiologist at Weill Cornell Medicine. I wish I could be with all of you at the ASA conference today, but I am clearly here in my apartment in New York City. So, what do I have here for you today? Well, the thing that you're seeing in front of me is a 3D virtual object of a CT scan re-rendered as what we call a volumetric object. And so we can evaluate patients' pathologies and their imaging findings in a very different way than we traditionally would on a computer screen. This has been done using a number of different colorization scheming that creates various density and color for Hounsfield units on the scan, which is the way that we measure density in tissue. If we mess around with the filters, we can just get rid of all soft tissue and focus entirely on just bones. And as you can see, this is a patient who has had a previous occipital fusion down all the way from the occiput down to 1, 2, 3. And you can see that hardware presently. But we are anesthesiologists, so we think about more than just bones, which is why I will increase the density or increase the colorization scheme across a different set of Hounsfield unit filters. We have a lot of tools in extended reality that we don't have on 2D monitors, and one thing is that we can actually reframe objects to be sort of correct size, so 1-to-1, and you can even start to see that this patient in the CT scan had what looks like a neck brace. So here we can use 3D cuts in order to do things like evaluate where the fusion lives to our airway. So as you can see right here, there's the hyoid bone. Look a little closer and you start to see structures like the epiglottis, and with the right colorization, you can even see the airway right over here, which starts right around here. So this would be where our vocal cords are. Now in these views, you can do things like make cuts. So that would be a cut right there. That would be a secondary cut to allow for some comparisons, and you can even go so far as to start measuring distances. And marking and drawing. Anyway, this is an example of what's possible today with extended reality technologies, and I hope that many of you consider incorporating it into your practice.
And this is
Hello, everyone.
no, all for us. If you have any questions,
Thank you, Maria. That was excellent. That was pretty cool. All right. Audience, thank you for participating. Any questions? You can come to the microphone if you have any questions. Okay. So either of you can answer some of these questions. I think the question as I was listening to this talk is like, how do we routinely, and you do an Occipito cervical OC fusion? I know, the surgeons kind of look at it and they, I see them, the screen. I don't always go and ask them, what do you think about, the post-op airway? Maybe perhaps I should, right? And we do a lot of KREs and Occipito cervical. We are also a level 1 trauma center. So this is made me think harder about this talk. So what do you think we should be? How do we get our surgeons to communicate better with us?
well, I just talk all the time. I personally talk to our surgeons constantly to the point of sometimes they run away from me. I believe, yes, communication. They have seen the bad part of things. We have had cases that came fused from other institutions. They already had a PEG tube. They were not easy to intubate. We have had emergency trachs. And they don't want to do those outcomes in their own cases. So they have been very careful. We communicate all the time at the beginning of the case. When they have any concerns, they communicate to us. If sometimes they tell me from the beginning, I don't know if we will be able to extubate this patient because they are concerned on the positioning and the other comorbidities that the patient had. So I think establishing good communications and working relationships, I think, is so important. So they're like in the Airway model, so they're working on that too.
So I think for us, it's many different anesthesiologists take care of these patients because these are traumatic injuries. It's not sort of part of a planned and very intentional clinical pathway. I think the mindset has to be that OC fusion is not just any fusion. Oh, I'm doing a fusion. No, not doing a fusion. And I think that we had our interest in this topic stems from a real tragedy, and luckily the patient neurologically did okay, but I think the overall outcome was terrible. And we looked into it, and I think we have become aware that extubation, I think that's the take-home message, is extubation is as important an element of airway management as intubation. And now that we understand the mechanics, it's very, this is like a constant thing, or we just say to them, okay, let's just look together at the x-ray at the end. Or if you don't want to do an x-ray, they all use the O-arm, right, for screw placement, so then you can reconstruct the airway patency if you don't want to measure the angles, because, you know, obviously I don't feel like I'm totally qualified to do this. But maybe we can learn. It's not all that complicated using, you know, the imaging software. But at the very least, we can look at the airway diameter.
I guess a couple of questions that come to my mind is this something you see the morning you get there, or did you know about this ahead of time? Question one. Question two is, I didn't see the armored tube. You guys don't use armored tubes. Question three is, on some of these, why not do an elective trach and work backwards?
Right. So,
those are my three.
yeah. So the question number one, do I always know? I mean, I wish I did, but no, I don't always know. Because, you know, there was something else on the schedule. This is trauma center. We have a very chaotic schedule because of the disruptions that are related to. So I'm scheduled to do the patient, and somebody else may take care of this patient tomorrow because it didn't get done today because they needed some other diagnostic tests on this polytrauma patient. So I don't always know. But when I know, we obviously have these conversations ahead of time. I think more of us are aware of it now because this is something that, you know, throughout the department is recognized as a potential problem. So that's answer number one. I don't think an armored tube is going to help you because it's not like there's an airway compression that the armored tube withstand forever. I mean, ultimately, the tube has to come out. And the point I was trying to make is that obviously if there is the patient I presented, that patient had a cerebrovascular injury, blunt cerebrovascular injury. So the patient had actually pre-vertebral swelling and a hematoma. The patient should not have been extubated, in my view, immediately in the OR, irrespective of the airway geometry. But if there is no anterior manipulation and there's been no injury that involves, you know, any kind of prevertebral swelling, that the swelling is not the problem. It's the mechanics of the airway geometry that are a problem. And removing anything that's stented, whether be it PVC or armored or whatever you have, is going to create a problem. And this patient, weeks later that I showed you, she still had laryngeal edema. I mean, the flexion was so extreme that you know, lymphatic outflow from the upper airway was inadequate. That's just a terrible outcome all around. And many of these patients, even those that breathe okay, have dysphagia. So they have some level of compression. And the final question you had was?
Do an elective trach and working backwards.
Right. Well, you can do an elective trach, but if the patient agree to it, you know? Like, are they going to agree to have an OC fusion? Oftentimes, these fusions in the trauma setting are done because of cervical instability, fear of neurological deterioration, but they can be treated conservatively for some time. So that's something that has to be discussed, obviously, but I don't think that that's necessarily a viable option for everyone.
You prefer nasal versus oral?
I don't have the same perspective because our patients are patients who have a normal airway anatomy, who then becomes distorted because of the angle of the fusion. But Dr. Bucillo's patients are completely different because she has all these complicated deformities that come to her with a priori problems.
It's case by case. On the hyperflex, in my opinion, nasal goes better. On the Klippel file patients, nasal goes better, at least for me. But other patients, I have had the patient that I presented there, I did an oral, and it was fine. She was not hyperflex. So an oral fiber optic works.
Just a quick comment on the elective trach. You know, what do you do with that trach afterwards? That trach has to close at some time unless they are willing to live with that trach the rest of their life, right? So that probably is not a great option. So we got to kind of, you know, maybe at the end of the procedure, look at the angle and talk to the surgeons and before we extubate the patient to if the angle is so acute, we may have to talk about decreasing that. All right,
So,
we are
you know,
on the last
Right. What I take away from this, I cannot tell you, our data is, I mean, it's a very, very small sample. It's clear that it's a mechanical obstruction. I think we're all clear on that there's no, I think, doubt about it. Now, how much of the flexion, what is the angle, et cetera, I don't think that's been completely worked out yet. But in my book, if you're going to extubate and there is no airway swelling, then you should do it in the OR in completely controlled circumstances with a cricothyroidotomy or tracheostomy kit and somebody ready to help you. Because if you send them into the wilderness, this is what's going to happen. A little nasal airway, a little oxygen, a little this, a little that, and then I finally call you, and it's an impossible airway.
Yeah.
And you cannot ventilate.
I guess to your point, do you ever think about extubating these patients over like a Cook catheter?
Yeah, you should.
Yeah.
I mean, if you have absolutely, but if there's a mechanical obstruction, it's only going to help you reintubate, maybe. That's why you should do it in the OR. You can't send them with a Cook catheter to the ICU.
Joe, one last question, please.
I was just curious, just talking about your anesthetic technique. Are you guys running TIVAs? How are you planning to run your anesthetic and then wake them up crisply enough in the OR? Because we all have time pressure. Regardless of the complexity of the case, there's always time pressure. So just kind of curious about how you're ending these cases to wake them up ready to go.
So we're very lucky. I have to say, I have an absolutely unbelievable regional anesthesia team, and we do some fancy blocks, including the fascial blocks for cervical spine, CCP block. And so a lot of these patients don't really need a lot of narcotics postoperatively. Actually, it's really amazing how little they need. So yes, I use usually remifentanil with propofol, and I am very experienced at PGY-X, so they always wake up very quickly from that. Now, question is why extubate, why not extubate, that's separate. And I use very little opioids, very little. Like I start with fentanyl because I just have no idea how much they're going to need, and because of the block and the quality of the block, and then I take it from there. They're very awake.
Just answering about the time pressure, it is a real thing, right? We are all running 3 rooms sometimes, and one is waking up, one is to be seen pre-op. So that is real. So that's when I guess we in our group, I'm at Vanderbilt, we call, we have like a group text that goes to all the neuro people and say, hey, I need help in such and such a room. So that's what we do. We get our colleagues to help us and have an extra person stand by. So I think it is a real thing that all of us are facing, especially these days.
So we do TIVA for everybody because everybody has neuromonitoring during the procedure. I do use opioids because my population actually, they are not opioid naive, most of them. So we do use methadone at the beginning of the case, but we usually wake them up with no problem. They don't take longer to wake up because it's TIVA or gas. We do it all the time, so they wake up. We time them, and they wake up faster.
Thank you, everybody. We can talk outside if you like.
Thank you.
Thank you so
Thank
much.
you for coming.